I'd like to now introduce Dr. Ronnie Frielich, who comes to us from Cabrini and Monash Medical Centre. Ronnie is a neurologist and neuro-oncologist and specialises, his main job is really working with the brain tumour population. So welcome, Ronnie. Thank you.
Thank you, Diane. I'd like to thank the organising committee for inviting me to speak this morning. Now, the title of the talk was Ins and Outs of Seizure Management, but I thought I should discuss the ins and outs of seizures themselves before we can talk about the management of these conditions. Now, so by definition, what is epilepsy? Epilepsy means two or more seizures. It's semantics. A single seizure is an epilepsy, but two or more seizures or fits is epilepsy. And just people get a bit confused with terminology, and I'll spend a bit of time going through terminology of these conditions. If you look at the general Australian population, it's thought that about 4% of people in Australia at some point in their lives will have a seizure, be it when they're young or they're very old. So it is a common condition in the general population. In the general population, the highest incidence of new onset epilepsy is actually in the older age group, over 65. It used to be thought mainly in kids, but mainly most common in the older population. So it is a common condition, not just in people with brain tumours. Epilepsy can either be primary or secondary. What does this mean? In a primary epilepsy, there's no underlying structural abnormality. So people are often born with a tendency to have seizures. And when you look at the brain, there's nothing abnormal in the brain to trigger a seizure. In the secondary epilepsies, there is a structural abnormality, be it a brain tumour, which obviously we're talking about today, stroke or hemorrhage or any other abnormality within the brain that then triggers a seizure. So in the primary epilepsy, there's something at the biochemical level, microscopic level, that's triggering seizures. In a secondary epilepsy, there's a structural abnormality within the brain that's triggering a seizure. What happens within the brain? Well, the brain is full of nerve cells, and these nerve cells communicate to each other via electrical impulses. And there's normally an even passage of electricity over the brain. One part communicates with the next part via electricity, and it's all nice and even. But in a seizure, there's an excess of electrical activity. And when that electrical activity becomes excessive, then that translates to some dysfunction or overfunction of the nervous system, depending on which part of the brain it affects. Seizures can be either focal or generalized. In a generalized seizure, it means that the whole brain is firing off and the whole brain is becoming active. In a focal seizure, it means only part of the brain is firing off. And what we can see and commonly see is that focal seizures can become generalized. So in other words, they start in one part of the brain and then affect the rest of the brain. In secondary epilepsy, such as with brain tumours, the seizures always start as focal seizures at the area where the brain tumour is, and then spreads to the rest of the brain. So it's typical for patients with brain tumours to have focal seizures that then can become secondarily generalised. It doesn't mean patients will always have focal seizures, but they always start focally in one part of the brain. Now, seizures are due to irritation of the normal brain cortex. A model of the brain. I know you've all seen sort of MRI pictures and so forth, but that's the outside of the brain. And just to explain some of the terminology, the cortex is really where the grey matter is. So the grey matter is on the outside of the brain, the white matter is on the inside of the brain. It's a general thing. In the grey matter, there are the nerve cells. This is where nerve impulses start. And in the white matter, the tracks from the nerve cells, from the cell bodies that go down, the spinal cord will come up from the spinal cord to the cortex. So nerve cells in the grey matter, in the cortex, the nerve tracks through the white matter. And seizures occur when the cortex is involved. So as a general rule, the grey matter, those cells in the outside of the brain, have to be involved to get a seizure. And that can occur, be it to the tumour, due to edema or swelling, or even scar tissue after surgery or scar tissue after radiotherapy, can all irritate the brain and lead to a seizure. It also explains why patients with tumours that are more superficial, around near the surface of the brain, are more prone to having seizures than patients whose tumours are deep. So for example, patients with cerebral lymphoma, that tends to occur more deep within the brain, around the ventricle, away from the cortex of the brain, are less likely to have seizures from patients whose tumours arise on the covering of the brain. In a focal seizure, where the lesion is dictates what part of the brain is affected, dictates the type of seizure someone has. So the same way that if someone has a tumour that's near the motor cortex, they will have weakness. If a seizure arises there, they may get jerking on one side of the body, maybe just an arm or maybe just a face or the whole side of the body. If it's near the sensory cortex, they may get a sensory seizure, and often is a march of symptoms going up a leg, then up an arm and to the face, this sort of marching of sensory symptoms. If it's in the visual cortex, in the back of the brain, they may get visual symptoms, in flashing lights and so forth. If it's in the temporal lobe, you may have some unusual type of seizures, such as déjà vu. Now, déjà vu is common, everyone gets them, but in epileptic déjà vu, the symptoms are often very intense and often quite frightening. And often patients can have hallucinations with temporal lobe seizures, often olfactory, which means they can smell things. Often people describe an unpleasant smell that they remember from many years ago. That's often part of a focal seizure starting in the temporal lobe. Often we refer to complex partial seizures or simple partial seizures. The differentiation of these is there impairment, is awareness impaired? So if awareness is impaired, so a bit confused or not a bit drowsy, then it's a complex partial seizure. If they're fully awake, patients are fully awake and fully aware, then it's a simple partial seizure. For example, just sensations down one side or jerking of one side without loss of consciousness or loss of awareness. And as I said before, focal seizures can become secondarily generalized. And in this situation, as I said, the electrical disturbance that starts in one part of the brain, then spreads to the rest of the brain, and produces what used to be called a grand mal fit, but now called a generalized tonic-clonic seizure, where typically patients become unconscious, they stiffen, the limbs stiffen, there can be jerking of the limbs, they may lose control of urine, they may bite their tongue, muscles are often sore afterwards, and people are typically confused and sleepy after a seizure. And if you ask a patient who's had a generalized seizure, what's the first thing you remember? The answer is usually the ambulance coming, because the time it takes the ambulance to come is usually the time it takes for them to wake up, about 5 or 10 minutes. As I said, in patients with brain tumours, the seizures always start as focally and then become generalized, but you may not see a focal seizure. So sometimes people could have, for example, jerking of one side and then go into a generalized seizure, or there may be no focal onset, just straight into a generalized seizure. But electrically within the brain, it starts in the one area. Sometimes people can have what's called a Todd's paresis. Traditionally, Todd's paresis means that after a seizure, patients can have weakness on that side that had the seizure. It can last for up to 2 days. In rare cases, often briefer than that. And always the worry is that after a seizure there's increased weakness. It means this tumour has progressed, but you can just have a Todd's paresis, meaning their pre-existing symptom is worse just because that part of the brain's been activated, that part of the brain, if you like, has become fatigued, and the symptoms are worse. In the same way, you can have a Todd's paresis, with paresis meaning weakness. You can have speech becoming worse after a seizure, or numbness becoming worse after a seizure, or vision becoming worse after a seizure. But these are temporary symptoms. Doesn't always occur, but it's not that uncommon. It can last up to 2 days. Not everyone with a brain tumour has a seizure. As I said before, the more superficial it is, the more likely it is. But even patients with very superficial seizures, superficial tumours, will not necessarily have a seizure. The seizures may be the first manifestation of a brain tumour, or they may develop during the course of the illness. And really, it's very unpredictable. In patients who've been well controlled and if seizures appear during the course of the illness, it does not necessarily mean that a tumour is worsening. It's the first thing that patients and families always think of, the first thing we always worried about. But just because you have a seizure in the setting of being controlled, well controlled for a long time, doesn't mean that the tumour is actually getting worse. And it's quite common for a patient to come in, has a seizure after a couple of years, the scan shows no tumour recurrence, but it's the scar tissue that's left behind from surgery and radiotherapy and so forth that's triggered the seizure. Now, individual seizures aren't harmful, so a brief seizure isn't harmful. Potential problems if there's a prolonged generalized seizure, if you have recurrent seizures, several in a row, or if people are in a dangerous situation such as driving, swimming, or doing things such as using chainsaws or climbing ladders and so forth. Now I thought I'd talk about the common causes of triggers for seizures, and this really applies to all patients with epilepsy. And I suppose the commonest situation I see when someone who's been very well controlled with their epilepsy for a long time, the commonest cause for them having a seizure out of the blue is missing medication. It's probably the commonest cause, not just with brain tumour patients, but in all patients with epilepsy. The second commonest cause for patients who are well controlled having a seizure is missing medication. And just in case you're wondering, the third commonest is missing medication. So, cannot emphasise enough, it's important to take medication. I have some patients who say, "Doc, I beat the system, I only take it once every 2 weeks, I'm not having a seizure, see, I didn't really have to take it." I have other patients who miss it for 2 hours and have a seizure, which is the more uncommon scenario. But it's very important, if you can, whatever you do not miss medications. Some medications have long half-lives, which means it takes quite a while for their levels to build up when you take it, and quite a while for their levels to drop down if you miss it or don't take it. And what can happen is that if you have a seizure, you may have if you have miss your medication, you can have a seizure within a couple of hours, or you may find you miss medication Monday and have a seizure on Wednesday or Thursday, because the levels have dropped down, haven't come back again. So we cannot emphasise enough the importance of taking medication. The other things we see is alcohol and drug use. Alcohol lowers seizure thresholds, which means that patients are more likely to have a seizure because their threshold is lower from that. Alcohol can also interact with some of the anti-epilepsy drugs and lower their levels. Recreational drug use can lead to seizures, and sleep deprivation can lead to seizures. And in the general population, what we often see as neurologists is 18-year-olds who go out drinking at late night for the first time and have a seizure at age 18 when they've done that. Treatment, this is the important bit. What we do is that if people don't have a history of seizures, we don't keep them on anticonvulsant therapy. The surgeons will often start anticonvulsants at diagnosis or around the time of surgery, just to stop seizures around that period. But if the person's never had a seizure, we taper the medications off after the surgery is done, because we know the risk of having a seizure is no greater or lesser being on medication or not. So if you have a seizure, you stay on medication. If there's no seizures, no history of seizures, and you've been put on medication around the time of surgery, we tend to take people off medication. There are many different drugs, and all drugs can cause side effects. And the perfect drug, if it exists, is the one that stops fits and causes no side effects. And often we can get it right the first time, but often we have to change or add drugs or increase doses. The aim is to eliminate seizures altogether. Sometimes we have to be pragmatic and reduce seizures to acceptable levels. And that applies not just in patients with brain tumours, but everyone with epilepsy. But it's a difference also for patients having recurrent grand mal or generalized tonic-clonic seizures, or if their seizure only is numbness in the left hand for a few minutes. You're going to push harder to try and suppress the grand mal seizures long term than to really push it so hard that people are drowsy from medication if all they're having is numbness in one hand or one foot. And as I said, you can certainly add drugs which may help further, but sometimes the more drugs you give causes more side effects, so-called polypharmacy. There are only several drugs we can give intravenously through a drip into a vein. Some are listed here: Dilantin, clonazepam, and Keppra. In emergency situations, these drugs are often used just to try and get levels up to stop seizures from happening. Oral medications. For many years we had Dilantin, Tegretol, and barbiturates, phenobarbital. In the 1970s, Epilum came along, and we also had clonazepam or Rivotril, which is a cousin of Valium. And really until the 1990s, that was it for our medications for epilepsy. But since the early 1990s, there's been many drugs come around. Some are listed here: Lamictal, Neurontin, Trileptal, Topamax, Keppra, Glucosamide. I won't go through each drug individually. A few points to make though. What is a dose of one drug isn't the same as another drug. So in other words, 1 milligram of one drug doesn't equal a milligram of another drug. So a milligram of clonazepam is like 1,000 milligrams of Keppra, for example. So there's no equivalence between the two. But with some drugs, if you double the dose, the drug level goes up 10-15 fold. So sometimes when we increase doses of medication, only very small increments, whereas other drugs we have to increase it by much larger amounts to get a better level. We mentioned before about not missing medication, and the question is what to do if you miss a dose of medication. As a general principle, it's always good to make it up later that day. If you miss the morning dose at 8 o'clock, you take it, if you remember at 12 o'clock, take it then. It depends a little bit on the individual person and the drugs you have. It's always worth discussing with your doctor what to do if you miss medication. As a general rule, it is worth making it up. If you miss it Monday, it's no point taking it Tuesday or Wednesday. It's far too late. The other question we often get asked about is generic medications. Drug companies put out drugs, and after a certain period of time, other drug companies can put out cheaper versions of the drugs, which benefits the population, cheaper drugs and so forth. The problem with generic anticonvulsants is that they may be slightly different to the original brand. So although a drug may be 100 milligram of the original and 100 milligram of generics, the bioavailability, which means that how much of the drug actually gets into the system, gets into the brain, may be slightly different between the generics and the standard drug. And you see people who've been changed from a standard drug to a generic and they have a seizure, or they have a side effect from the drug, because the level that's available to the body and to the brain is either slightly higher or slightly lower than the original drug they were on. So as a general principle, if you're taking one brand of drug, it's fine to continue on that brand of drug, but the problem can occur if you swap from brand to brand, from generics to standard to different generics and so forth. So as a general principle, we prefer people to stay on the one type of one brand of drug. Anticonvulsants cause side effects. I'm listing a few side effects that they have, but not everyone gets side effects, of course, but things you can experience are drowsiness, dizziness, unsteadiness, nausea. Some drugs make you put on weight, some drugs make you lose weight. You can become moody or depressed, or not as sharp as normal, as people say. Fatigue is common. Hair loss can occur with some drugs. Some drugs cause kidney stones, tingling in the hands and feet, word-finding problems. Rarely allergic reactions, rash, fever, rarely severe reactions. Abnormality of liver function tests, abnormalities of blood counts, which are important for getting chemotherapy, or even visual disturbance. The list looks terrible. Most people don't have a lot of side effects. It's exercise that people worry about side effects. You open up a MIMS, the drug book, and put your finger on any drug, and you'll get a whole list of drug side effects that are there. But with each individual drug, and again, not every drug has these side effects, with each individual drug, if you're made aware of the side effects that they can have, you can look out for it and let the treating doctor know. And one of the issues is that with new drugs coming on board, we see new side effects. So there was a very good drug called felbamate that came out in the 1990s. It was one of the newer anticonvulsants that came out, one of the first new anticonvulsants, which is a terrific drug. But after use for a year or so, it was found to cause liver and bone marrow toxicity and was taken off the market. So newer drugs can cause newer side effects. And the anticonvulsants can interact with other drugs, warfarin, and sometimes even with some chemotherapy drugs. So it's important to look at those interactions with the medications. Sometimes the side effect profile of the drug can overlap side effect profile that patients have due to their tumour, so fatigue and dizziness and so forth, and sometimes it's hard to know. Sometimes, for example, with patients with fatigue, we take them off the anticonvulsant in case that's causing the fatigue, but the fatigue is no better after we take them off that drug. And the important thing is that any particular drug may work really well for one patient and cause no side effects, but may not work for another patient and cause terrible side effects. And it really goes with any treatment we have for any condition. Drug levels. We do drug levels as a guide. but the general principle is we treat the patient, not the blood test. So if we see a patient where the drug level is low, but they're not having fits, we don't increase the drug dose. If we see the drug level is a bit high, but there's no side effects, we don't necessarily decrease the dose. We treat the patient, not the blood test. With many of the newer drugs, we don't or can't do drug levels. It's actually made life a little bit easier for us to not worry about drug levels, but we still do monitor for things like liver toxicity and bone marrow toxicity with routine blood tests. When do we increase the dose or change drugs or add drugs? Well, obviously if seizures continue to occur and are bothersome, and again, it depends a little bit. If someone has a partial fit every single day or a minor fit every 3 months, it'll influence us how much we change the medications. And also we change medications if there are side effects, obviously. And again, we often get asked, why didn't we increase the medication before the fit occurred? Well, we don't know we need to increase the medication until the fit occurs. And if a patient has 10 fits a week, it's quite easy to tell if the drug is working. If it's 1 fit every 10 months, it's much harder to tell if the drug is working or not. Treatment. Well, apart from treating the actual anticonvulsants, treating the tumour itself can treat the seizures. So surgery, radiotherapy and chemotherapy can all have beneficial effects in epilepsy in patients with brain tumours. Often in patients with low-grade tumours, we often watch patients and observe and start radiotherapy or chemotherapy when needed. But in patients with low-grade tumours who are having a lot of seizures, often treating the tumour at that point may help the seizures themselves. Lifestyle issues. A lot of this is really being common sense and being sensible. Patients with epilepsy should have showers, not a bath. If you have a seizure in the shower, the water goes under you. If you have a seizure in the bath, you're under the water. Obvious danger there. You don't go swimming on your own. Always make sure there's someone near you. And beware of operating dangerous machinery, climbing ladders and so forth. It never ceases to amaze what I get asked people can and can't do with epilepsy. I saw a patient a few years ago on a Wednesday who had 2 new seizures on a Tuesday and asked could they go skydiving on a Thursday. And I said, not a good idea. And I said, it's okay, it's piggybacking on someone else's canvas. And that's 2 people at risk. Not a good idea. It's really common sense. If you're having active seizures, don't climb ladders with chainsaws near a swimming pool. First aid, and this is really important for everyone there. The person having the seizure often isn't aware of what's going on, and these seizures are often frightening for people who see them. Even people who see them a lot, it can be quite frightening and scary. And it's important to just be calm initially and just go through a few basic principles. So keeping a patient out of harm's way, if they're near a dangerous object, about to fall off something, or protecting their head, that's important to do. Once they're over the seizure, this is really for more grand mal seizures, once they're over the seizures, you should roll them onto the side to help protect the airway. It may be difficult to roll someone who's actively convulsing. It's maybe difficult, but afterwards you help roll them onto their side. Many years ago it used to be said to put something in their mouth to stop them from choking on their tongue. It's the worst thing you can do. If someone's having a generalized seizures and the mouth is clenched tight, if you put a spoon in their mouth, they'll break their teeth. If you put your fingers in their mouth, they'll break your fingers. Do not put anything in their mouth. When to call an ambulance? This is always a question we get asked. And there's a few principles. If it's a prolonged seizure, so more than 5 minutes of convulsion, so if someone's convulsing, a tonic-clonic seizure, stiff and shaken, actually convulsing for more than 5 minutes, should call an ambulance. If there are recurrent seizures, so a patient hasn't fully regained consciousness within 5 minutes and has another seizure, then you call an ambulance. But I also tell people, if you're worried, call an ambulance. You're better off calling the ambulance, you can come. And the ambulance officers are very good. They'll, if they think it needs to be, they'll bring the patient to hospital, but often the ambulance officers will call me directly or call the doctors directly, say a patient's had a seizure, they're happy with them, they're settled, we'll change the medications and make an appointment as an outpatient. But if you're worried, call the ambulance. Most seizures are brief and self-limited. Anyone who's seen a seizure, they can say that seconds can seem like hours. And if people will say, look, seizure goes for 20 minutes, but it really isn't. But most of them are brief and self-limited. After a major seizure, patients will sleep and then recover. And the best thing is sometimes to let them sleep it off. sometimes less is more. And I give the example of seizures in public places. If someone who has epilepsy has a brief seizure at home, goes to sleep, recovers, terrific. But if they have it in the deli section of Coles, then all hell breaks loose. The ambulance comes, they get drips put in, they get taken to hospital, they're there for 4 or 5 hours, and all they say is, please let me go home. And I remember a few years ago I was walking out of a restaurant in Ackland Street, and someone had a seizure on the footpath right in front of the restaurant, and I went there, and actually, as I was another passerby who was a nurse, went there, and we basically kept the patient safe. She'd actually flown from Sydney the day before and didn't take her medications. And basically the ambulance came and took her, which was appropriate. But there was a crowd of about only 30, 40 people just looking and trying to give advice and everything. And the poor girl was surrounded by people. And thankfully it was before there were mobile phones with videos. Everyone was videotaped it. This is a slide, I don't know if you can see this, but this is through the Epilepsy Foundation of Victoria, and this is a good slide showing seizure first aid. I will go through it, I think it is important, and if anyone wants to access this, it's readily available on the Epilepsy Foundation website. So the first one's a tonic-clonic seizure, the convulsive seizure with loss of consciousness, muscle stiffening, falling over followed by jerky movements. Keep calm, as I say, note the time the seizure started and until it ends. Protect the head, use a pillow or cushion, it's important. Remove any hard objects that could cause injury. Don't attempt to restrain the person or stop the jerking or put anything in their mouth. As soon as possible, roll the person on their side. As I said, you may have to wait until the seizure movements have stopped. Talk to the person, make sure they have regained full consciousness, and stay with them and reassure them until they've recovered. And for that first post-ictal period after a generalised seizure, patients are often confused, sleepy, confused, and can sometimes be quite aggressive or agitated as well. The focal discognitive seizure, that's really the complex partial seizure, where people don't really a partial seizure, but losing awareness and depressed conscious state. And again, the same thing. Don't restrain them. Talk to them, until they've fully regained consciousness, and stay with them until they've recovered. And they've said here, I hope you can read it. Call an ambulance, as I said, for any seizure. If you don't know the person, and no epilepsy management plan, if the seizure is more than 5 minutes, the seizure recovers, but the person doesn't regain consciousness within 5 minutes, or another seizure occurs, or obviously if there's an injury or the seizure's in water, and it says here if someone's pregnant as well. I know there's a session for driving coming up, but I do have to mention driving, since it's so sort of intimately tied in with epilepsy. As someone who's on the driving committee has said, driving is a privilege, not a right, and it's purely a safety issue. If someone has seizures with loss of consciousness or loss of awareness, that can impair their ability to drive. If there's cognitive impairment or physical impairment, that can affect their ability to drive. And all these factors are taken into account really in the population in general. And we're really bound by this national document, which is the Assessing Fitness to Drive. This has sort of now become a sort of national guidelines that we have to adhere to. And really this booklet covers all medical conditions, not just neurological conditions, but cardiac conditions and so forth as well. A couple of things. After initial seizure, Vic Roads say you cannot drive for 6 months. After brain surgery, the book is probably the vaguest after brain surgery. There's sort of a recommended but not definite 6 months after brain surgery. If we're worried about any ability to drive, we get an OT driving assessment. Patients who have a heavy truck or bus licence, the restrictions are much longer than for regular road users. And in anyone with any medical condition that can affect their ability to drive, Vic Roads have to be informed. And that means even with people, for example, multiple sclerosis, respiratory disease, diabetes, in theory have to tell Vic Roads. And the routine is Vic Roads know, sort of contact the doctor, who then gives a detailed report to Vic Roads about the driving ability. So that's really covering all the area of epilepsy and epilepsy management, and I'd be happy to answer any questions anyone may have.